All right. Good afternoon, everybody. I know you've had a long day, so we'll kind of make this one go down a little bit easier. You guys are tired. My name is Stu Blatt. I'm a physical therapist. I've been a PT for the last 30 years. I've been working with people with Parkinson's for about 20 years. I've been associated with Michigan Parkinson's Disease Foundation for the last 10 years or so. I'm part of the Michigan Parkinson's Disease Foundation, the Medical Advisory Board. And so they've asked me to talk a little bit about exercise and Parkinson's. When we talk about exercise, we're really not talking about exercise. We're really talking about balance. Because the real goal when it comes to exercise isn't to make you stronger, but to help you improve your balance. So that when we think about it, if you're doing a lot of weights and you're lifting weights and stuff, this really isn't the goal for Parkinson's. The goal is really about balance. So with that being said, let's talk a little bit about what we're going to talk about today. The goal here is to identify, my bad, sorry about that, is to identify the components of balance. So we're going to talk about what makes balance, what are the components of balance, to differentiate between the factors that are neurological and those that are physiological that control balance, to compare and contrast the various interventions that we have out in our community that work on balance that you have for people with Parkinson's, and lastly, to talk about how do you promote balance long-term? How do we get you to do things on a long-term basis? So balance is a product of four things: your eyes, your ears, your muscles, and your receptors in your joints. And the only one of these that's truly directly affected by Parkinson's is your eyes. The rest of them are not directly affected by Parkinson's. And because of that, we have to look for programs that help strengthen these other three areas, but not to forget about the eyes. So when we talk about balance and vision and balance, what happens is inside your eyes you have what they are called cones and rods. And these things transmit signals back to your brain and tell you where you are in space. And it gives you a sense of orientation relative to the other objects, and it tells you when you're walking around the street where the buildings are, and it gives you a sense of vertical alignment, where you are in relation to everybody else. And what we know about people with Parkinson's is a lot of people with Parkinson's don't keep their heads up. They look down. And that's because the way your eyes and the way your muscles in your eyes are working, you're not scanning, you're not looking around. So a lot of people with Parkinson's tend to keep their head down. And to illustrate this point, let me show you two quick little videos. The first video here is a person walking with their eyes up, with their head up. And look what happens when they walk. So this is point of view. This is the person walking. So when you're watching, you feel pretty balanced. You feel pretty calm. Everything's okay. Because you're getting orientation from all around. You're seeing the walls over here. You're seeing things over here. You're getting things in the background. So you have a sense of balance. Now watch what happens when you look down. You don't feel so balanced. You feel kind of weird, everything's a little uneasy, because the minute your head goes down, it changes your orientation. You have no place where you are in space. And that's why it's so important as clinicians that we constantly are telling patients to keep their heads up. If you want to, because the more that you learn to keep your head up, the better your orientation and the better your balance becomes. Because if you get stuck in this forward flex position, you have no sense of orientation and your balance diminishes. But in addition, we have to start having you learn to use your eyes so that when you're doing an exercise program, and those that were in the earlier group today at 1 o'clock where we had three different groups, two different clinicians showing different types of programs, every one of them had you using your eyes. Because it's so important to integrate your vision into your therapy. If you're not integrating vision into your therapy, we're losing part of the battle, because vision tells you where you are in space. In addition, we have the inner ear, the vestibular system. And one of the things about the vestibular system is it's not directly affected by balance. And the vestibular system tells you where you are in space. It's a gyroscope. When you move your head, you have these three little canals that are inside your inner ear. And they have fluid inside the ear. And whenever your head moves, the fluid rushes from one place to another, and it tells your brain when you move from one position to another. And these systems are intact. The problem with people with Parkinson's is you don't use your head enough. So you don't move your head, you don't rotate from side to side, and you're not getting that fluid from going from side to side. Let me show you what it looks like. So here's this little video here.
I just want to talk about VSP
That
Direct.
wasn't what I wanted, sorry about that.
VSP is the #1 choice in vision care. They offer...
Oh, that's not what I wanted.
It's final exams week, and that means...
That wasn't what I wanted. I screwed up. Well, let's see if I can bring it back. No. Oh, well, forget it. Oh, there it is. Hey, it's back. Sweet. I am so inept when it comes to computers. So this is the person's head. This little area in here is the cochlea. This is the part of your brain that tells you where you are. That's your gyroscope. These are these three little canals that we're talking about. Oh, there we go. Watch what happens. So here's the person's head. Here's the fluid. When they go from side to side, the fluid moves from one place to another and tells you when you moved from one position to another. That's the one they call the posterior canal. Now they have the superior canal, this one right up here. And this one also has fluid in it. And when you bend your head forward and back, that fluid rushes from one place to another and back and forth. All of this is all intact when you're working with people with Parkinson's. That fluid is still moving all the time. And then you have the one on the side called the horizontal, which is when you rotate from side to side, when you look from side to side. This fluid is going all in different directions. And because it's all there and it's intact in people with Parkinson's, not only do we have to have you using your eyes to know where you are in space, we have to have you starting to rotate your head. So you're moving from one position to another, that you're moving in different body positions, that you're going from your back to your side to your stomach. Because the more that we have you moving around in space, the more you're moving this fluid around. But what happens with the majority of my friends and people who I know who have Parkinson's is a lot of people don't move, and you don't have good, what we call cervical rotation and cervical motion. So you keep your head in a really fixed position. And what we say is, oh, people with Parkinson's have poor balance. No, you don't have poor balance, you have poor movement. And we have to get you to move more because exercise isn't about strength. Exercise is about balance. We have to help you improve your balance through movement. So balance isn't, when we talk about balance, we're talking about basically strength. But it's not being bulked up. You don't need to be stronger. You need to have what we call core muscle strength. Shoulders, hips, backs, and stomachs. You have to be able to anchor your body. And if you can't stabilize at your core, you cannot move well. And this is where people with Parkinson's tend to have a hard time. They're very weak in their core muscle strength. So the exercise programs that you want to engage in should engage you so that you're using your core muscle strength. You want to do activities that increase your stomach muscles, that increase your back muscles, your shoulders and your hips. Because those are where, if you can't fix at the core, you can't move out here. In therapy terms, we talk about it as proximal stability, distal mobility. If you're not stabilizing at your shoulder, you can't use your hand. So if people are having a hard time with their hand, putting a weight in your hand isn't going to make that hand work any better because the problem isn't at your hand, the problem's at the shoulder blade. You've got to go back and work at the shoulder. So if you're having a hard time with walking and teaching you to do a heel strike when you walk isn't going to help you learn to walk because the problem isn't at your feet, the problem's at your hips. And if you have a weak stomach and a weak back, you have to constantly keep going back to the core because the core is where all balance starts and originates in the core. Everybody kind of with me on that? Does that kind of make some sense? Okay. All righty. But sensory input. Sensory input is about where you are in space and how you're going to move in space. And this is where people with Parkinson's really have a hard time, is knowing where they are in space. Have you ever had it happen to yourself, or you're with somebody, your spouse, or you're working with a patient who has Parkinson's, and they stand in front of you and they fall backward, and they fall like a tree in the woods? Kinesthetically, you didn't know when you lost the vertical position. You didn't know when your body went backward, and the signals that go and tell you that you're losing that position aren't kicking in. And this is why we have to start putting you in positions where you have to learn to lose and catch your balance. Balance is a product of use it or lose it. If you are not using your balance and you're sitting in chairs that lift you up and take you to stand, and you wonder why you can't transfer, because you're not using that skill set that teaches you how to transfer. You have to do the bed mobility to get bed mobility. It's really about working it, that the better your balance becomes, the stronger it becomes. Now, I've been blessed for the last several years that I have several exercise groups that I run, and these people are very kind to me, and they show up every week when I show up to exercise, and they're there. And I have a group in Ann Arbor that's been together for 10 years. These people show up every Thursday to exercise, and they're doing more 10 years later than they were when they first started, and they had less Parkinson's 10 years ago, yet they're stronger now. I have a group in Rochester Hills that's been together for about 5 years. They have been exercising for the last 5 years, or 3 years actually. I think they're probably 3 or 4 years. But they've been together, and they're doing more exercise now than they've ever done before. I have a group in Howell that's been together for 7 years. And all of these groups, and I have a group in West Bloomfield that's been together for a little over a year now, and every one of these individuals their exercise program is much harder now than it was when we first started. And it's not because of the Parkinson's isn't getting any better. The Parkinson's is a progressive neurological disease. But what we know is the more we challenge their balance, the better their balance becomes. And ultimately, the better your balance is, the safer you are, and the less likely you are to fall. Because balance is a product of use it or lose it. Everybody kind of with me on that? So that when we talk about balance, we talk about it in two forms: proprioceptive and kinesthetics. Kinesthetics are where you are in space. So when you stand up, do you know that you're standing straight? Or do you think like, this is straight, and your kinesthetics is telling you that this is straight, and we all look at you and go, hey, you're leaning to the right. But they go, no, I feel straight, because kinesthetically, you do not know where your vertical is. Proprioception is where your joints are in space. So if you close your eyes and you make a fist, you know that your fingers are closed, because the joint receptors in all those joints are telling you that you've made a fist. And so you need these two components to work together in order to improve function. So if a therapy program that you're engaging in, it doesn't make a difference if they're not engaging you into where you're losing and catching your balance, that you're working on your kinesthetics about where you are in space, and also working on the proprioception about where your joints are in space. Because proprioceptors, those little receptors in your joints, are based on pressure. They're pressure receptors that tell you where you are in space. So you want to do a lot of activities where you're putting pressure on your hand or pressure on your knees, because the more that you put pressure on those receptors and you drive those joints together, it tells your brain where that joint is in space. So programs that you're engaging in should engage in activities that challenge your balance, that challenge your core strength, but also working on the kinesthetics and the proprioception, trying to get your eyes and your head also working at the same time. Everybody kind of with me on that? Thoughts, questions? Okay. But there's a whole host of problems that have nothing to do with Parkinson's that cause people to lose their balance. And this is something we have to be really cautious about, because dehydration is probably one of the number one reasons why people lose their balance. They don't drink enough water. Now, we know that people, as they get older, the studies are countless on how many people who, when they get older, do not drink enough water. And we've heard this time and time today throughout various presentations that we've heard, that people with Parkinson's are dehydrated. You have to start drinking more water. If you're a therapist and you're treating a patient, you have to make sure they drank water before you start the therapy, and you have to make sure that they're drinking water during the therapy. Because you may say, oh, their balance is awful, but the problem is, it's not balance, it's dehydration. Dr. Goodrow mentioned that there are some systemic problems that will cause your symptoms to get worse. And a lot of my clients that I work with, people that I work with who have Parkinson's, will go, oh, my Parkinson's is so much worse. My tremor is so bad today. And I'll say, have you had much water today? And they said, no, I've been drinking they have this really tall glass of water, and they've been sipping at it all day long, and they've got a quarter of the glass is gone. That's dehydration. Drink water before anything else. When your symptoms get worse, if you were fine and your symptoms are worse now, drink some water, because water, if you start to become hydrated, you start to see that your symptomology is going to get better, because we have to make sure that you're drinking ample amounts of water. The best thing I tell my clients and people that I work with who have Parkinson's is every time that you take your pills, and if you take your pills 4 times a day, you have to drink a glass of water. Now, it's not the juice glass, and it's not the real tall one. It's the one that's in the middle. You know, you guys all know what I'm talking about? There's that middle glass. It's about 6 to 8 ounces. Every time that you take your pills, if you drink that 1 glass of water every time, and you drink 6 ounces of water 4 times a day, that's 24 ounces of water. That will give you a base for drinking water. And then everything you drink beyond that is gravy. So now we start with a base, but you have to have a base for hydration. If you're not hydrating and you're doing exercise, you're going to have problems with your balance, because dehydration leads to balance problems. Everybody, okay? I'm sorry? How much water? Oh, sure. Catch it. Another big one that causes balance problems, malnourishment. People with Parkinson's are not eating enough food. They're not eating enough calories. If you have a tremor, that tremor is burning calories all day long. So you have to increase your intake of nutrition to maximize the capacity for what you're eating, what your movements are. So if you have extraneous motion, that's burning calories. So you have to make sure that you're eating enough. So before you start therapy, make sure you ate something before you went to therapy, and then make sure that you're eating stuff periodically throughout the day. Because people as they get older tend not to eat as much, and they become malnourished. And the research is very clear on elderly, and what we're finding is people with Parkinson's fall into that same category. Sleep deprivation. We just heard from Dr. Goodrow that there are some medicines that make you stay up at night. But we also know that people with Parkinson's are not very good sleepers. They tend not to sleep real well. So they might get up. People, when they get older, don't sleep real well. So then we add Parkinson's to the mix. And what we find is that you get up once or twice in the middle of the night, or you have a hard time falling asleep, or when you wake up, you don't feel rested, and therefore you're sleeping during the day. If you're not feeling rested, your balance is going to be diminished. And none of this has to do with Parkinson's. This has to do with a better lifestyle. We heard one of the speakers earlier today talking about a schedule. Getting yourself on a schedule. You go to bed at a certain time, you wake up at a certain time. We are all creatures that like schedules. All your life before you had Parkinson's, you had a schedule, and you adhered to that schedule because it makes us efficient. And we all like to be efficient. So the more that you start to work on you have set times, your body will start to learn what to do during these periods of time. Anxiety. Everybody, there's a question? Okay. Anxiety. Anxiety makes your symptoms worse. Anxiety makes everybody's balance worse, because when you're anxious, you don't challenge yourself. And we were hearing there's several presentations today on the issue of anxiety. If you have an issue of freezes, anxiety will make your freezes worse. Those oftentimes, because I have a lot of the people that I work with and people that I know who have Parkinson's, and they'll tell me, when I've got to go to a restaurant, forget it. Because if I don't go right to the table when I walk in and I got to stand at that hostess station and wait for that hostess to seat me, my freezes get worse, because in their brain they're going, oh, what if I can't move? And so the more that you become anxious, the less you're able to move. The less you're able to move, the worse your balance is. We have to find ways to help people reduce their anxiety. There are strategies that we all use when we become anxious. Deep breathing, visualizations. Some of these, not every anxiety issue needs to be medicated, but sometimes you just need to recognize that I need to practice that skill set. I need to work on that skill set because we have to figure out ways to reduce their anxiety. And a lot of times if you go to a therapy clinic where you're anxious about exercising in front of a whole group of people, it makes your therapy less effective because now you're in an environment going, are they all looking at me? They're wondering what's wrong with me. And they may not be looking at you, but in your brain, you're perceiving that they are. And all of these factors will have a direct link to your balance. And they have nothing to do with Parkinson's. They have all to do with the way our body responds to outside forces. And then lastly, the one that really has the greatest impact on balance, sedentary lifestyle. The majority of people with Parkinson's have a very sedentary lifestyle. They sit, they take their medicine, and they watch TV. And this is where a lot of the time, so there's countless amounts of research on exercise and Parkinson's. And they will always compare the exercise group to people that just take their medicine. And guess what? The people who just take their medicine never get better. Because medicine without exercise doesn't promote function. So we have to find ways to keep you engaged, to keep you moving. Whether it's doing your morning routine and dressing yourself and doing your own showering, or whether it's doing a walking around or getting involved in an exercise program, you have to increase your activity level. Sitting around and that sedentary lifestyle reduces one's balance. Okay? So when one is looking at an exercise program should engage the core muscles, shoulders, hips, backs, and stomachs. If you're doing a lot of stuff where you're doing it with your hands and you're doing stuff with your feet, you're not getting the core. You've got to go back to the core. Yes, sir?
I used to have a standard bicycle at home, stationary bicycle. I'll do like 2 miles at night.
I love it.
Is that good?
Yep. Any movement is good movement. If you're riding a stationary bike and you're sitting up and you're using your balance, that's a good day. Anytime that you're doing stuff, it's a good day to do stuff. So you want to find things that you will engage. So if you're going to a program, a more formalized program, whether it's a formalized PT or OT program or one of the other programs that are out there, it should engage your shoulders, your hips, your back, and your stomach. And if anyone went to that previous session at 1 o'clock, they all were engaging your shoulders, your hips, your back, and your stomach. Because all of these programs that are out there are designed to do that same thing, engaging in your shoulders, hips, back, and stomach. Because again, that therapeutic principle, proximal stability leads to distal mobility. The more you're stronger in your core, the better you're going to move away from your core. Balance. You have to have activities that challenge your inner ear, that are making you turn your head from side to side, that are making you move in different positions, because we want that fluid that's inside your ear to move all in different directions, because the more that moves, the better your balance becomes. We want to engage your eyes. Doing activities that make you use your eyes, because the more you use your eyes, the more it gives you input about where you are in space. You want to do that. You want to also do activities not only that engage where you are, so you're working on your balance, but you also want to engage in activities that stimulate those receptors, that tell your joints where they are in space, because we have to build a better mousetrap. Because the more that we work on all of these factors, we start to see balance improve. So again, working on that vision, tracking an object with your eyes, turning from side to side, doing those activities, because the more we do that and you're moving your head, you're triggering all these responses that we're looking for. Don't forget to breathe. People, when they exercise, tend not to breathe. They tend to hold their breath. So we want them either doing activities. So what we were doing today in that previous group, the Brock Steady people were having them count out loud. They're having them do activities by, singing the alphabet. You know, the people from the Mark Morris program, we're having you sing the song, we're doing activities. All of these things incorporate breathing because it's not just the activity, it's the breathing as well. But the most important thing when it comes to an exercise program is desire. Do you have the desire to do this program or do you not? I was watching some people with the Mark Morris program in the group, and they weren't engaged in the dancing. Dancing doesn't speak to them. That's okay. But I watched those same people when they were doing the boxing thing, they were moving during the boxing thing because that spoke to them. Some people, it's the big and loud program. It doesn't make a difference what program it is. The fact is you have to have a desire to do it. If you don't have a desire to do it and your spouse is making you do it, it isn't going to work because you have to do it yourself. Somebody else can't do it for you. You have to do it for yourself. So we have traditional PT and traditional OT programs that are out there that are wonderful. Clinicians are out there and they're doing great skills. We've got the Big and Loud program, and we have the new program, the Power program. Those are programs that are out there that are people who have training and part with people who are in those programs. The Rock Steady program was that was the boxing program that we saw. We had the Mark Morris program, the dancing program for people with Parkinson's. There's the Delay the Disease. That's a program that's out there. There's the Pedaling for Parkinson's, where you ride a bike and you have someone tandem bike riding. That's out of the Cleveland Clinic. You have Tai Chi and yoga and Pilates. All of these programs have one common factor. The individual, they have several common factors. First, the individual is engaged in the activity. It's using your core, your shoulders, your hips, your back, and your stomach. You're using your eyes, and you're challenging your balance. So all of these programs, so it's not like, oh, this program is better than that program or this one. It's the one that speaks to you. Because if it doesn't speak to you, it could be the best program out there, but if you don't want to do it, it's not going to it's not going to help you because it's about your desire. You have to want to do it. So again, all of these programs the person was actively engaged. The program was challenging the person with Parkinson's balance. The program addressed the core sense of weakness, and it also increased their heart rate and their respiratory rate. Heart rate and respiratory rates have to go up. Now, it doesn't have to be, if you ask the people who do the pedaling for Parkinson's, they say it's 80 to 90 revolutions per minute. That's pretty fast, and that's pretty high. Most of us can't do that. But what I found over many of my years of clinical experience and working with people with Parkinson's is it's whatever is going to get your heart rate up. Sitting in a chair and just doing this isn't going to get your heart rate up. You actually have to do something. So if you're finding that your heart rate's going up and it's more than what it was when you first started, that's a bonus. That's gravy. The stronger you get, the more your heart rate will increase. But to try to hit an arbitrary target number isn't really the benefit. Is it more than it was than when you first started? Because that's really what it's about. And I was reading a PT journal right before I came here, and they had an article in the PT journal that talked about Parkinson's and exercise. And they looked and they said, okay, which program is the most effective? And they weren't looking at those programs. They said, let's compare a home exercise program to a program where they're going to a clinic, and look to a third program to where they went to a group. And lo and behold, they found that the least effective program for people with Parkinson's is a home exercise program. Because what we know is when we give a home exercise program to a person with Parkinson's, it doesn't get done. And I have nothing but love in my heart for you guys, but it's not just Parkinson's, folks, it's Americans. As Americans, we like the idea of exercise. We really just don't like the idea of actually doing it. And so that when we're left to our own devices to actually have to exercise, it isn't going to happen. But they find that individualized programs do quite well. But the problem with an individual program is, if you don't want to go to therapy that day, you call in and say, I'm not feeling real well today, and you don't go. So therefore, the therapist doesn't come and make you go because it's really up to you to decide to go to the clinic. So it's more effective than a home exercise program, But it has its limitations because it's up to the individual to go to the clinic. But the one that they find is the most effective when it comes to people with Parkinson's is a group. Because it's not so much they like the exercise program, is they like the group. We are creatures that are social. We like to be out there. And when you're with another group of people who have Parkinson's, you feel comfortable because now you're with your own group of people. You have people, now those of us who know people with Parkinson's or who work with people with Parkinson's, we appreciate the struggle that you have, but we don't know the struggle. But when you're in a group with a whole group of people, all who have the same condition, they may not have the same symptoms, but they understand something that the rest of us who do not have this disease do not understand. We appreciate it, but we don't understand it. Does that kind of make some sense? Okay. Are there thoughts and questions people have about the program? Yes? Right, absolutely. It was a biased study because it was looking at one set of variables. Home exercise program, being able to get out to the clinic. You're 100% right. It's a whole different animal than it was compared to a home care therapist situation. But what we all know is, typically, in most of us who are clinicians, the first thing we do when we have a patient is we give you the obligatory home exercise program. And we expect that this is going to carry you through. On the next time I see you, you're going to do your home exercise program. Like I said, I have nothing but love in my heart for you, and I do the obligatory home exercise program, but I recognize that it's not getting done because it's just not something that we do on a regular basis. There was another question, yes? It was the January issue of the Journal of Physical Therapy. Yes?
I love what you said, and
well, thank you.
I don't necessarily think it's not like part about the group.
Mm-hmm.
But I found a way, I was diagnosed 12 years ago, and one of the first things that got me into exercising was walking in the mall.
Mm-hmm.
And I did not compare myself to people that I thought had Parkinson's. I would say, I'm going to see the person that's 2 stores down, I'm going to walk faster than that person is to the next store, start in little bites, and I never backed away from things, and it's been one of the most best times in my life in many ways. I've met some people that talked about some things I wouldn't have done otherwise, but be determined that you're going to stay ahead of it because you will.
And you're 100% right. If it works for you and you found that getting into the mall and challenging yourself, that's probably who you were premorbidly, that you had a sense of this internal drive. So you have to look at the individual and what works for you. And there is no one big program. If anyone tells you they have the program that's for people with Parkinson's, they don't. Because it's all about the individual. You have to take the program and tailor it to the individual because everybody has these most unique needs and desires. Well, that's that's a whole other discussion that happened in a whole different session. But I'm recognizing, yes, sir.
Going back to dehydration, why is it water and not water or juice or soft drinks, something non-alcoholic?
Water typically is the best because it's the one that has the least effects outside of your body. Now, if you're drinking pop, if you have caffeine is a dehydrator. So if you're drinking Coke and it has caffeine in it, when you're trying to rehydrate yourself, you're actually dehydrating yourself. Juices are great too. If you'd rather drink juice than drink water, rock on. But the thing is, you have to start drinking things that are going to be better for you rather than always drinking things that are going to be that are going to have a negative effect. And you have to get more water, you have to get more liquid into your system. Try to stay away from the caffeinated beverages. Other? Yes? Right, and that's where your speech pathologist, you have to work with your speech pathologist. So they're asking about, if you have swallowing disorders that precludes you from swallowing. That's a whole separate issue, and you want to talk to your speech pathologist about how do we get more calories in. I tend to find that someone who has a swallowing disorder, smoothies and milkshakes are really great. Someone who's on a thickened diet, you make a really good smoothie that has a lot more, there's a little bit thicker to it. That take care of a lot of those problems, because now you're staying within the consistency that they can drink, but you're giving them more nutrition because now you're using vegetables and you're using fruit and you're making something that way. Those Ensure drinks, if you turn them into a milkshake and you throw in ice cream and you throw in some other stuff and you make it really thick, that tends to take away some of the swallowing problems. So you have to look at your speech pathologist on the kind of consistency that they're asking for, and then figure out how do we get that into their system given the constraints of the swallowing disorder. Does that kind of help? Other thoughts or questions people have? Yes, in the back. Walking? I love walking. I think walking is a great thing, but walking isn't enough. Because sometimes when you walk, yeah, you're walking and you're doing better, but you also have to get back into that core muscle strength. You have to get back to that core to keep challenging your balance. So walking is great. I love walking, but we have to add another layer to it, finding out what else can you do to keep yourself moving forward. Yes?
Wait a second.
You know, the recumbent bike, any activity that you're going to do is going to be great. We have to find ways to increase their activity level. So whatever you're comfortable doing and something that you're going to do on a regular basis, that's where you start. Sure. And if you're working it, you're going to be, if you're doing this, you're going to be using your core to get that going. Absolutely. Yeah. Aquatic therapy is where you do exercises in the water, and aquatics is a really great thing, especially a lot of people who are afraid of walking, because now you're walking in the water and you're not afraid you're going to fall down and get hurt and those things. The problem with aquatics is it's gravity eliminated, which means there is no gravity. Buoyancy is holding you up. And the strength training research that talks about gravity eliminated says the muscles that are trained in a gravity eliminated environment do not fire the same way when you take them out of the gravity eliminated and you work them into a gravity where there's gravity pulling you down and you have to use different muscles. So if it's a place to start, that's great. If you're going to mix and match, that's even better. But to rely only on one aspect of it isn't always going to be the best way. You want to mix and match and try to give them a holistic approach to their overall care. Pilates was on my list. I like Pilates if you're going to do it. The question is, it's not what it is, it's that you're going to do it. We have to find ways to get the individual engaged because it's really about the desire of that individual to do that activity. Oh, karate? Was it karate, not Pilates? Karate is, anything. I said, if you have karate and that's your thing, then rock on. Like I said, it's all about doing whatever you want. Yes?
Hi. I work in an acute care hospital setting, and often I'm getting patients with Parkinson's who've sustained hip fractures and they come in for other ailments also. How do I, with a short time frame, how do I work my therapy session at the most optimal time? I've tried to ask patients when is the most optimal time. A lot of times they can't really tell me, but then I'm working around the hospital too.
Right. I used to be an acute care therapist, so when I worked in acute care in mid-Michigan, it became my mission to get people with Parkinson's onto our rehab unit. I would do everything in my power to get them onto rehab because people with Parkinson's could never get enough rehab, and people with Parkinson's are the perfect rehab candidate because you never went to the hospital for Parkinson's. You go to the house Parkinson's because you have a hip fracture, now you have a hip replacement. So the rehab unit wants people with Parkinson's because you have what they call a dual diagnosis. You're a complex medical case, which means your reimbursement goes up. So hospitals like you because your reimbursement goes up, but it's a win-win situation. The patient gets what they need, but when you're in a hospital, two things are critical when doing therapy in a hospital. First, make sure the medication is given before you start doing the therapy. I had a situation several years ago when I was working there, a person with Parkinson's fell down a flight of stairs, fractured their shoulder, had their shoulder repair. I was going to see the patient. The nurse said, "Oh, he has his medicines. He's ready to go. We're good." And I went to go see the patient, and he was as stiff as a board. And I said, "He had his Parkinson's meds?" And she goes, "No, he has pain meds." Because when they have an orthopedic injury, they don't think Parkinson's, they think orthopedic. And as clinicians, we have to make sure they're getting their medication and getting their medication at a timely manner. Yes? 5 minutes? Okay. All right. All right. So it's really about when you're working there, but on the acute, so when you're working on acute care, timing with the medicines and timing when you can get in and get them going is the key. But to try to get them onto the rehab unit is our #1 goal. Other thoughts or questions people have? All right. Well, I think we're done here. Well, thank you very much. Have a great day, everybody, and thank you for coming.